Welcome to our monthly dialogue. As you know, these are true Socratic dialogues, very inspiring among editors, authors, readers, and they are very interactive. They are live streamed in YouTube and Twitter. Better now, X is the official name. And then they will be posted in X and YouTube. So if you miss the opportunity today, those who miss the opportunity today will have a chance to follow our dialogue also in the future. Today is a very stimulating dialogue with Professor John Deanfield. I'm hosting Professor Deanfield with Professor Libby, who is Executive Editor of the European Heart Journal. And I think you know by now that I'm Filippo Crea, Editor-in-Chief of the journal. You know that the dialogues are very interactive, so please ask questions. You can write your questions in the chat, or you can raise your hand. Can be the true hand, or can be the virtual hand, but show that you have a question to ask, and we will involve you directly. So the meeting the dialogue as usual will be very interactive. And the topic is extremely interesting. The title of this dialogue is How Investing in Children Can Change Life Trajectory. A fascinating story narrated by John Deanfield. And now, Peter, please, can you introduce Professor Deanfield, and then we will start the dialogue, please.
Yeah, I'd be delighted. John was at Cambridge, and then he did pediatric cardiology and adult cardiology, and I'm an adult preventive cardiologist, and I'm in total awe of anyone who actually understands cyanotic congenital heart disease, particularly when it's been fixed 2 or 3 times. And so John adds to his repertoire not only the usual portfolio of a preventive cardiologist who looks after adults, but as we will explore and learn about in this dialogue, he has a particular commitment not only to congenital heart disease, but to prevention in children. John's curriculum vitae spans 90 pages. He has over 550 publications. He has a stratospheric H index of over 150. And I'm not going to take any time reciting his titles. Let me simply say that for those of us who are not in the UK, we're in unabashed admiration for someone who has the initials CBE after their name, which stands for Commander of the British Empire. So I don't know if that means that the Bobbies salute to you when you're crossing the street, but we're honored to have you with us today. And so I first encountered John when he was working on endothelial function in the early days, and I was working on endothelial biology. And we engaged in many educational activities together, and we both have international practices, and we've shared patients from Turkey to Brazil. So it's a real pleasure to be on. Now, what was it that drew you to pediatric cardiology, which is this arcane and complicated field?
Well, Peter, it was serendipity, it was chance. In the UK, the training programs don't usually include pediatric cardiology for adult cardiologists, but there was one program that several eminent people had done, which had a year of a secondment to a famous children's hospital called Great Ormond Street, which is the world's first children's hospital, specialist children's hospital. And I went there to learn about pediatric cardiology from my adult training. And I was blown away with the whole change in culture and what I saw there. GOS is a hospital that has its motto, the child first and always. And it really was an astonishing place. Really, you felt that everyone was pulling together in a way that is not typical in a normal adult hospital. And it was wonderful from that point of view. The other thing that was great at that time, this was the 1980s, and lots of things were changing in the management of pediatric patients with congenital heart disease. So at the beginning of my year, the mortality for certain conditions was about twice it was at the end. And that wasn't due to me. That was just the advances in the management of congenital heart disease that were so rapid at the time. So it was an incredibly exciting year, and I really loved it. But I did go back to the Hammersmith after that to continue my adult training. I then got a call a year or so later saying, would I like to consider going back to Great Ormond Street as a permanent career? And after a lot of reflection, because I was excited by stuff I was doing in adult cardiology, I'm sure Filippo will bring that up because we were working together. But I went back to Great Ormond Street to do two things, really. To do prevention, which I'd already started to think about, but also I thought there was a role for an adult cardiologist to look after the long-term consequences of all of these triumphs of the management in childhood. So I was bringing it together as a sort of hybrid, if you like.
But there are actually two bookends, right? The adult congenital heart disease, we're dealing with arrhythmia and heart failure, right ventricular failure, pulmonary hypertension, and a lot the patients that I see and take care of as inpatients with adult congenital heart disease have all of these terrible complications. So you have one foot in that camp, and then you have the other foot in trying to prevent heart disease, acquired heart disease. So how did you actually germinate your interest in the other end of that spectrum?
Well, I'm really, to be really honest, what I did was to use my adult skills to address some of those issues you already mentioned in congenital heart disease. And I love the clinical work. The clinical work is the most exciting because it's incredibly challenging. I used to talk to the students about Star Trek cardiology. We were boldly going where no man had been before, because actually there were no papers to read about these management of these patients. You were doing the thinking, if you like, on the job. And that was very stimulating and quite challenging, as you can imagine. But the other thing I loved about it was you got your patients, became friends with them for life. There are lots of patients that I've now looked after for 40 years in their cardiology management, and that's incredibly exciting. You look after the patients, their children, the whole families are involved, and it's been an amazing clinical experience. But I did come from Hammersmith, having worked in coronary disease. And when I got to the Children's Hospital, I realized that these were the next customers for the future generations of heart disease. And actually, if we were going to do something about it, it just dawned on me that instead of treating the disease in its later clinical manifestations, we ought to be thinking about what we could do to prevent it in the first place. So it was an overlap between the ages, but the two themes actually were really important in the young, and no one was actually doing that at that time.
So you actually don't have a favorite child, it seems, that you, instead of seeing a polarization between the advanced adult congenital heart disease and prevention, you see them actually as a whole, a spectrum, a continuum.
Yeah, I think that's probably right. There are two areas, but actually now they are actually coming together. So as the adult congenital patients live to 40s, 50s, and 60s now, they now are subjected to all the same risk factors and the development of acquired heart disease. And probably the next big challenge in the management of those patients, we've dealt with their childhood care very effectively. We now can manage with evidence-based medicine much of the problems that you've been talking about, arrhythmias, heart failure, and the like. The next challenge is going to be the coexistence of acquired heart disease on top of potentially vulnerable circuits that these people live with until they develop acquired heart disease. So I think these things do come together in a very exciting way, and I'm very interested in that going forward.
So Filippo, you go back farther with John than I do because you intersected at the Hammersmith. Maybe we can dial back the clock and talk about those heady days.
Yeah, thank you, Peter. That was a wonderful time. The last month, our guest was Bill McKenna.
Yeah.
And John, I'm sure you remember those memorable times. We shared the office with you and Bill. And at that time, well, Bill McKenna was there and has become the guru of cardiomyopathies. Kim Fox was there, past president of the society and past editor-in-chief of the European Heart Journal. It was really an incredible melting pot with colleagues from the 5 continents, very enthusiastic period. And in particular, we were close to 3 giants, John Goodwin and Celia Oakley, who proposed the first classification of cardiomyopathies. And our classification is still based on what they proposed. And then Attilio Massari, who launched this provocative hypothesis that ischemia can be caused not only by stenosis, but also by functional alterations. So it was really a very active, pleasant, interactive period. What do you remember from that period?
Well, you've already described some of the giants, but also some of our colleagues who all worked together. It was an extraordinary place because it's a hospital, as you know, in not the best part of London. So you have the sort of background hospital and its delivery of clinical care. But on top of that, you had these extraordinary people coming from all over the world to work together. It was an interaction between people from different backgrounds and different cultures that was, I thought, incredibly exciting. A whole load of Italians, as you know, came over with Attilio and had such a different culture in the way of working from the traditional English trainees, that just that was a learning experience. Now, if you then put together people interested in different disciplines in medicine, you know, heart muscle disease, you talked about Bill McKenna, who was working with Celia and John Goodwin. You had a coronary group that we were all working with together. You had imaging, PET scanner. It was the first PET scanner in Europe that we had at the time. These were all incredible things in an institution which at that time, I think, had an unrivaled expertise in clinical physiological research. So it wasn't a great basic science center that we'd had there. What we had was clinical medicine and really robust clinical and translational research going on in a way that was actually very, it was unique. And this wasn't just in cardiology, the whole culture of the place was amazing. You had liver specialists, Sheila Sherlock there, you had all sorts of people there in all the other brands, all sharing that very, very robust and very formal interest in genuine clinical research. And I thought that was unique.
Yeah, and it was a prolonged time where really this interruption produced very interesting results. I still remember the first time, I don't know if I told you in the past at that time, but the first time I went to Hammersmith, I went by underground. And you must know that Hammersmith Hospital was on a really very, very poor area, was just a street with two buildings. So I left the underground and looking for the Hammersmith Hospital, and I found these two huge buildings side by side, and the what appeared to be the better looking building was on the left, and I knocked on the door, and it was a jail, because Hammersmith Hospital was the other building, but the jail was in better shape. Watched from outside.
I knew you'd say that,
was
Filippo.
really a unique setup. And really many of us have been really found our roots there, and these roots then developed very well in different directions. And coming back to mentors and important colleagues in our life, John, after the Hammersmith, who are the other colleagues who inspired your scientific life?
Well, I think I have to pay tribute to Attilio. We both worked for Attilio in those heady days at the Hammersmith. Attilio was extraordinary because he was a charismatic individual who did bring a different approach to coronary disease that was prevalent at the time in the UK. We were in the beta blocker era of cardiology, demand-driven ischemia. We all thought this was a fixed stenosis with a change in demand that we could modulate with drugs and occasionally bypass surgery. And here came this extraordinary Italian who said, no, it's different. It's a physiological disease with all sorts of causes of disturbances in flow that we need to understand. And I found that inspirational. And you remember, I was working on silent myocardial ischemia, the whole pathophysiology of ischemic episodes that didn't require chest pain to have a problem. And we were characterizing their pathophysiology with PET scanning and all sorts of things going on at the time. And so it was extraordinarily exciting. This was discovery translational clinical science. I think it's its best. And Attilio was really the agent that changed thinking at that time. I had a fantastic colleague, you'll remember, called Andrew Selwyn, who is another link with Boston. Now, Andrew was working at the Hammersmith, and he had come from South Africa, trained in the UK. And Andrew was very interested in myocardial ischemia. And he was working with me to characterize these disturbances of blood flow and metabolism using PET scanning, ambulatory ECG monitoring, and correlating that in patients to really, I think, rewrite some of the story about how ischemia develops in patients during their normal daily lives. So he was another big influence. And of course, when I went to Great Ormond Street, there was a whole different cast of characters that influenced me. One of them was a man called Marc de Laval, who sadly died. He was a cardiac surgeon from Belgium. He sadly died last year. Marc was an extraordinarily good surgeon, but he was a scientist, but also someone with a deep, deep concern for patient care in a way that I admired enormously and became very close friends with Marc over the years. And Marc was unique for a surgeon. He would think hard about not just the successes he'd had in surgery, but every time there was something went wrong, he would really think deeply about how we could avoid that. And he did something unique that shaped my thinking about medicine. He reported in a paper in the Lancet at one stage a cluster of failures that he'd had with a particular operation called the arterial switch. He'd done hundreds of operations before with very, very good results, had a cluster of failures that were unexplained. And what he did to deal with them was extraordinary. He brought in an outside surgeon, another famous cardiac surgeon, to work with him and retrained for something he'd been doing for years successfully, excuse me, and then produced extraordinary results for the rest of his career. He didn't just hide that and pretend it didn't happen. He reported it in the Lancet as a cluster of failures and how to deal with that and what the root causes might be. That's not common in medicine. We don't normally report our bad results. And here was an amazing man to do that. So he was a huge influence on me.
And coming back to Hammersmith, also Dennis Krickler was there, who was really an important personality in the field of arrhythmias. But another guest at Hammersmith Hospital for 1 year is with us today, and very close to Attilio Massari is Carlo Patrono. I don't know whether you had some overlapping or Carlo came after you left.
I think after I left.
After I left. But perhaps Carlo can also give us some comments on Hammersmith at that time. Carlo, please.
Well, I had a wonderful experience working with Attilio between 1985 and 1986. It was the time when I was trying to develop the concept of low-dose aspirin for cardiovascular prevention. And I had a hard time to convince Attilio that platelets were important in addition to coronary vasospasm. We had great fun together, and it was also an opportunity to meet friends in Oxford who were starting to consider doing large clinical trials to actually test the hypothesis that low-dose aspirin would be effective and safe in acute myocardial infarction. I'm talking about Peter Slide, Richard Pito, and Rory Collins.
Yeah.
So it was a very stimulating year, and I learned a lot from Attilio and his colleagues, including the people who are present here today.
So for the young people in the audience, this is not just about walking down memory lane and celebrating. But the lesson for the young people here is environment counts. So John, you were lucky to be steeped in at least 2 Great Ormond Street and 2 environments that were clearly pivotal in your development. So young people listening, think very carefully about choosing your environment and then make the best of it. I think that that's the distilled essence of this. Now, Attilio Massari was remarkable. Most people have one idea during their career. They're lucky if they have one creative idea. But Attilio also, together with you, Filippo, and Giovanni Luzzo and Gigi Biasucci really put inflammation on the map in ischemic heart disease. We jumped on it in Boston, but you were there first. So Attilio really championed not just spasm, but also inflammation. And there are two areas that proved quite fertile and actually generative for many, many careers.
No, I agree. And it's interesting. I remember going from Hammersmith to Boston to the Brigham when Andrew had gone to the Brigham, and the first experiment with acetylcholine in the coronary arteries was done at that time. And here was another link between biology and vasomotion and coronary flow that changed our thinking about. It wasn't necessarily classical spasm, but there was this much more generalized problem of the health of the vascular wall that was driving disturbances in flow. And suddenly these things came together, and inflammation is obviously a key part of that disturbed biology from an early stage. And I think this idea that we could study not just a disease in a traditional way, but actually think through, make some observations clinically that change people's thinking, was an incredibly important part of my development.
Well, John, we focused on the environment, we focused on your trajectory and some of your work, but beyond the pole of the advanced congenital heart disease in the adult, you've now really developed quite a deep interest in prevention, primordial prevention with children. So that's how you wanted to title this dialogue, was investing. So what are your thoughts about that, and how can we do it?
Well, I can tell you the story of how I got into that, and it again links very much with Boston. When I got to Great Ormond Street, I was doing a lot of clinical work with children, but I had sadness of leaving the coronary environment that had been so stimulating. We've been talking about that. And I thought, how can I join these things up? And it was at that time when those experiments were done on coronary flow and endothelial function was being discussed. And I thought, this must be an early event in the development of coronary disease. So I sent one of my colleagues, a man called David Sellemeyer, I'm sure you know, who was my fellow at the time. I sent him to Boston. I said, look, go there and figure out how we can take this sort of biology and test it in our younger patients. And we came back with the idea that we might be able to infuse acetylcholine down the coronary arteries of young people to see how early endothelial dysfunction developed. But clearly, that wasn't a practical way of doing it. So we went out and developed a technique which I think has been really helpful in the change in thinking about atherosclerosis. We were able to develop a non-invasive technique using ultrasound on flow-mediated dilatation. So we used the flow stimulus to drive nitric oxide release from the endothelium in the healthy vessel, and demonstrated that as young as 10 and early years of age and earlier, there was a disturbed response to this endothelial-dependent relaxation stimulus. And that really took the sort of study of vascular biology, I would argue, out of the lab and into the population, into epidemiology. So we created, I think, a new field I called vascular epidemiology, where you could test vascular biology in children as young as 3, 4, and 5 years of age repeatedly and start to look at that long preclinical stage of atherosclerosis. And I was very excited about that because it represented now science to target not just the level of risk factors, but the impact it was having on the blood vessels of those young people. And that's where I became interested in childhood origins of adult heart disease.
And so you started out with bedside clinical research. You developed with David Sellemeyer the flow-mediated dilatation, which has become a cottage industry throughout the world, and really exploited the discoveries of Furchtgott and colleagues on endothelial function and endothelial vasomotor responses. But you recognize the problem, but you've now devoted a great deal of your current energy to national programs to try to promote health, not just in children, but also in those of us who are well past childhood. So can you tell us something about your leadership role at the level of UK in preventive cardiology?
Yeah, so when we started to study young people, we realized this was a disease that wasn't just an autopsy-related finding of atherosclerosis in younger people that was unexpected. This was really a disease that was evolving from early on in life. And it seemed to me that our approach in medicine was really naive in a sense. We were allowing people to be exposed to cardiovascular risk factors for 50 and 60 years of their life and waiting for them to come into our medical institutions with the clinical complications and trying to help them deal with them. So this was an idea that we had a 50-year preclinical window, which we ignored largely in our clinical practice. And we're treating the consequences later on with expensive, complex interventions that couldn't completely turn the clock back. So I felt that it was important to try and think of a way in which we could intervene early to get the benefit like we do for our financial planning. And I sort of thought this was just like our finances. So I use the analogy that, you know, none of us would think that starting to save for our retirement at 60 or 64 was a great way to ensure our financial future. And that's how we were dealing with this incredibly important disease. And that if we could intervene early, I called it investing in our arteries, we could actually get the compound interest from reducing the exposure to risk factors early and greatly improve the lifetime consequences in terms of prevention. So this was this idea of upstream investment for future gain that I was really talking about for years. Actually, no one was very interested in that, except it was a sort of bit of a curiosity for a long time. So I remember going on lots of meetings with you and others, and people were talking about, you know, stents, they were talking about surgery, new drugs and everything. At the end of it, I would get up and say, why don't we try and prevent this disease? And everyone thought it was very important, but not really very interesting. But suddenly it's become clear that we have to deal with prevention. And so as that becomes clear, for the reasons I'm sure we can talk about, healthcare delivery has got to change, and governments are now beginning to understand that for all sorts of reasons. So I'm now very involved in trying to get the government in the UK, and I hope international as well, to reframe, you know, healthcare away from just better disease management to genuine prevention, to unburden or reduce the burden on healthcare systems, which are struggling all around the world. So that is my role now, one of my roles, and it's proving interesting because we got to talk to a whole different set of people than we normally speak to in our normal clinical practices.
Yeah. So how do you actually do it? How do you implement change at a national level?
Well, first thing, things that happened to me, I'll tell you the story, is that I got invited to report to the Secretary of State in the UK as the health minister about prevention, because quite clearly this has reached the level of the politicians. And I was asked to design a platform over a year, this was actually last year, to allow this to come out of the completely stressed disease care system, the health service, and actually put it side by side and develop a longitudinal platform that could allow people to really understand the evolution of their disease and their risk profiles, and actually do something about it over that long period of time. So there's a whole load of things that we're trying to implement to support this. Obviously, the first is to educate the public on their opportunity and not just their risk. We have to get away from short-term risk calculators that we use in clinical practice to influence the prescribing habits and the clinical decisions we make, to a much more longer view, a lifetime risk model. So developing risk models that allow you to understand risk, but also benefit from early on has been a second challenge. And of course, we've got to get that out of the doctor environment. It'll never be delivered just in the healthcare system. So democratizing access to these measurements and to the communication is another big thing. Why do we have to do it in a GP or in a hospital environment? Why can't we get people to interact with their health during their normal daily lives? And of course, COVID has really helped us get that idea across to the public that actually managing your disease is of interest to you in terms of your outcomes. So developing longitudinal digital platforms that people can use to track and follow their risk in a way that is actionable at certain levels, and how we can then help them to deliver it is part of that whole strategy we're trying to develop and present. It's got some way, but of course, there's a lot of work still to be done on that.
So you've gone from the individual patient to actually influencing policy in an entire nation.
Yeah,
Also,
trying to do that, yeah.
You have tendrils going to Africa also.
Trying to do that because that is the big prize, isn't it? You know, we trying to solve the Jeffrey Rose paradox, if you like. You know, there were in the past we talked about finding the people at the highest risk who would then benefit the most from an early intervention for them individually, but not make much difference to population health. To the other end, where we advise people to do good things to the whole population and they produce a small benefit, but most people don't benefit very much, to create something in the middle, which is genuine longitudinal personalized prevention, addressing your disease, your risk factors longitudinally at scale in the population. That's the big prize, I think, that we're trying to do. Of course, population health is going to be critical now because we can't manage the sort of burden of disease in the population that is overwhelming our healthcare systems just by treating it at the late stage. So I think this applies to developed countries quite clearly, but it's going to apply all around the world as countries change in terms of the risk profile from infectious diseases, which are largely being overcome, to chronic diseases of aging, which are going to dramatically alter the profile of risk in other countries. So Africa is a beautiful example where non-communicable diseases are going to become the drivers of future ill health in the population, the way we can get in there early to try to address some of those things. So yes, I would love to work, and we're just starting to try and do this in Africa.
So Filippo, there's a question in the chat about inflammation. Maybe you want to go back to inflammation for a bit, since that's a common interest.
Yes, Dr. Perk is in the audience. I can read the question from him, but if he's with us, he can ask directly. Please, Dr. Perk, where do you live? Where do you come from? Can you hear me?
Yes, I do, yes.
You can ask your question personally.
I practice in Canada, and inflammation has gone through a large, for many years I have heard about inflammation, and mostly from cardiologist colleagues, but very few cardiovascular pathologists have taken part in these discussions, and I find this a little bit unusual in my view that someone who is supposed to tell us what inflammation is has no say in this area where we are now talking about inflammation in almost every cardiac variety of disease. So I would like to know if there's any reason for this, or what's your opinion about it?
Well, I would defer that to Peter Libby. I mean, Peter on this call has been the guru who's really made us understand the role of inflammation, not just in terms of basic science, but also in terms of the potential for intervene with clinical trials demonstrating about how reducing inflammation will produce clinical benefit potentially. Peter, do you want to comment on that before I come in with my views on it?
So Rudolf Virchow was a great pathologist, leading pathologist perhaps of the 19th century, and over 200 years ago, he recognized that atherosclerosis, a disease that many of us study, was an inflammatory disease. He called it an Entzündungsreaktion, and clearly described not only inflammation, but many other aspects that are strikingly modern, if you go back and read Virchow. But my perspective is that I've always followed in the footsteps of pathologists. Some of my great mentors, late Ramsey Cotran and Michael Gimbroni, were pioneers in endothelial biology and discovered the adhesion molecules that recruit the white blood cells, the inflammatory cells, to the early atherosclerotic lesion. And so I have been really a student of the pathologists, and of course, you don't see the pathologists' names on the clinical trials because they've been our inspiration and guides, telling us what experiments to do. And their time is much better spent teaching us and doing fundamental research than trying to manage sites in a large-scale clinical trial.
Mm-hmm.
But, you know, it's interesting, Peter, that the inflammatory biology that you just described, how important that is perhaps the common pathway to multiple clinical manifestations of disease in later life. So the common biology of inflammation, oxidative stress drives many of the diseases of aging we'd like to avoid in response to early risk factors. So I think it does two things for us. It tells us a target for treatment, but what it does is explain the fact that if we intervene early, not only do we get leverage gain against what we think we're treating, like cardiovascular disease, so this concept of investing in your arteries for future gain, but if you do invest early and reduce your risk environment and reduce that dysfunctional biology, you get leverage gain on multiple diseases. So obesity is a very good example. Obesity is a risk factor for heart disease, stroke, dementia, diabetes, cancer, all perhaps through common biological pathways, which are potentially targetable if you target them early. So you're not only going to get gain on an individual disease, but you'll slow or perhaps prevent many of the diseases of aging that could be avoided. So I think this is really neat because it brings the biology together, not only as a target for early intervention, but also an early intervention target for reducing many, many diseases at the same time. What do you think, Peter?
I agree completely. And I think that Filippo has been a pioneer in inflammation also. And I think he's been fascinated by some of your recent work on dental hygiene. Filippo?
Yes. Well, as we are discussing inflammation, I think that in front of us, we have really a big challenge. There's this recent paper published in the New England Journal of Medicine, a global epidemiological study, showing that traditional risk factors from Framingham, hypertension, diabetes, smoking, dyslipidemia, and obesity explain 50% only of cardiovascular disease. What is left, we tend to call it residual risk, but it's a massive residual risk. So I think that we have a lot needs to be done in the future in this regard. And my feeling is that this residual 50% risk is mainly driven by pollution, infection, and social isolation. These are three potent risk factors, perhaps more than risk factors we are not addressing. And in particular, infections, the infectious burden is there, which has not been addressed. And John, this brings me to a very important paper you published in the New England many years ago. It was a brilliant study, proof of concept, but published in the New England. What you did was to randomize patients to intensive treatment of oral hygiene versus standard treatment. And this was associated to lower levels of C-reactive protein, this simple hygienic intervention. And more recently, Tom Guzik did the same thing, and he found that good oral hygiene was associated to lower levels of hypertension. So I think that here we have a huge amount of work to do to reduce this 50%, which is not explained by traditional risk factors, and the mediator of this the residual risk, as you said, is likely to be inflammation. What is your attitude based on your direct experience, the paper you published in the New England, what we are learning, and in addition to traditional risk factor, what is your vision? How can we address this remaining 50% of risk?
So this is a really important question. I mean, the oral hygiene one and the periodontal disease is really interesting. It's by far the commonest inflammatory stimulus in the population. In the UK, about 40% of adults have an element of chronic periodontitis. So this is really prevalent in the population. What we did in that original New England paper was to demonstrate in a randomized clinical trial, as you pointed out, not only a reduction in CRP, but an improvement in endothelial function that occurred over 6 months in the peripheral arteries. So this was the first paper, I would argue, that took this from observational associations, which had been around for a long time, but often confounded by lots of factors, to one that actually showed that this was a causal relationship in a randomized clinical trial. We did another paper with a man called Francesco Dauto, who's an Italian dentist who works in London. And he's been working on this for years. And Francesco took people with diabetes, and he did exactly the same experiment and randomized them to effective oral hygiene treatment and a less effective treatment. Within 1 year, the HbA1c came down by nearly 1% in the patients who'd had the effective treatment. Creatinine came down, endothelial function improved in those diabetics within just a year. So not only could we demonstrate vascular function improving, but certain markers of chronic diseases seem to improve as well. So I totally agree that this is a potentially tractable and important cause that we've not recognized for the residual risk of chronic disease. Whether it's 50% or not, I don't know. But for sure, we have to look at even traditional risk factors in a different way, but explore other factors that may also be important for driving that inflammatory biology.
And perhaps we have underused vaccines, which is now we have really good evidence that viral infections predict cardiovascular risk, including papillomavirus and many others, and the vaccines improve cardiovascular risk. So really, I think that this new and pollution is another important aspect. I think that really we cannot afford to become unemployed. We have a lot to do before.
Yeah, I mean, Tom Munzel has been the proponent for the environment in terms and done some wonderful work linking it back not just to outcomes, but actually the biology of arterial disease. Beautifully done. I'm a great believer in that. I think, though, the danger when we start to talk about pollution and the environment and everything is we're starting to talk about things that are not directly in our control, in our ability to change them. So, you know, you can hide behind those a bit and say this is all too big for us. But actually, the tractable things we talk about in our practice, but doing them differently, doing them earlier, are potentially huge factors for the population. In the UK, there was a beautiful report from the King's Foundation that looked at health inequality in the population, health outcome inequality. And that's something really crucial that we all have to address, and is a very politically important issue. 80% of the health gradient in the UK was driven by potentially modifiable chronic diseases, mainly cardiovascular disease. So the difference in outcome between the different populations in terms of cardiovascular disease and chronic disease outcome was driven by these modifiable diseases. So losing weight, managing blood pressure, managing cholesterol has a huge impact, not just on individual risk we've been talking about, but actually reducing that risk gradient if we get it right and can access the people with interventions we already know work. So I'm a great believer in Tom's work, Tom Munzel's work and others, and it's incredibly important, but we shouldn't say, well, there's nothing we can do about it. It's beyond our control. We've got a real opportunity to manage risk profiles and exposures better and make a difference to individual health, but now I think to societal health, and doing something that's incredibly important.
Thank you, John. Carlo, please, you raise your hand.
Yes, John, I'd like to go back to your current interest in primordial prevention and ask you, what do you think about the potential role of education of children in elementary school about healthy lifestyle, particularly concerning food, smoking, and physical activity? What impact do you think this may have, and is it feasible in your assessment of the current situation?
So I really think it's incredibly important. You know, we teach Latin to kids at school, and we don't teach them about their health and their opportunity for the future. Which one's going to have a bigger impact on their future well-being? So I think we've got to look at the curriculum, we've got to look at children's health as an early investment in what we've been talking about, you know, and the way that we don't do properly. And it's not it's not as straightforward as you think. It's not just a matter of giving them a lesson or changing their meal. You've got to change the attitude of the whole family to health and the health of the young people. There was a famous celebrity chef called Jamie Oliver, who in the UK, you may know about him. And he got a bit fed up with all the doctors talking about this, and the politicians said, I'm just going to provide a healthy school meal, and that would solve the problem. So he introduced this healthy meal into the schools. The kids didn't like it very much. But the real problem was that the parents were feeding them Big Macs and hamburgers through the school fence after the meal. Mm-hmm. And these overweight parents were managing their children, and giving them the bad food. So this is not something you can target just on the children. We have to change family attitude to well-being and investment. But you're dead right. It is incredibly important. The statistics are scary for children. There was a paper in the New England Journal of Medicine a few years ago suggesting that if you're overweight or obese at the age of 2, you have an 80% chance of being overweight or obese at 35. And the WHO statistics said that about 50% plus of the current children will be overweight or obese by 30. So that's our patients for the next generation. They have diabetes, they have hypertension. This is an incubator for future cardiometabolic disease. And if we don't address that early, what's going to happen?
Yeah, there is an epidemic of childhood obesity, but people don't seem to care or to
so you're right,
pay attention.
So I am trying in the UK to take this out of just a discussion with the healthcare providers and the health minister, but actually broaden it to education. It's got an impact on health. Most importantly, we're talking to Treasury, because you'll never get traction if you just make this a health issue. This is now a health and wealth issue. Mm-hmm. So the productivity of the population, the health of the workforce is critical for our national prosperity. And that's now affected by these diseases. So I called it health and wealth in a recent lecture. Mm-hmm. It's just one letter difference. So now when you go to the health minister and say, I want to prevent disease, he looks at you and he says, I've got a waiting list. I've got doctors who are on strike. I've got ambulance waiting times. Don't bother me with prevention. And that's the problem. If you go to the Treasury and you say, if you deal with this, the workforce productivity that is 20% down in the UK from what it was before COVID can be addressed. They say, why aren't we doing this? So there's an opportunity to spread this from health to children, as you say, education, to Treasury, and to pensions and the like, because the pension industry is going to be crippled by the way in which we are managing health in the future. So this is going to be really, really important, I think, and spreads it out as something that's interesting, not just to doctors or healthcare providers, but the whole society.
Thank you. And we should work together at the European level, probably.
Yeah. I mean, these things, these trials that we're doing, now about risk factors, SELECT is an interesting one. Filippo was telling me before that he's going to be discussing SELECT in future dialogues. This was a trial that showed that a GLP-1 would reduce cardiovascular events. Mm-hmm. When we announced SELECT in August at the press release, the airline shares went up. The airline shares went up because they calculated on the back of an envelope that a 10% reduction in the weight of the population would reduce fuel consumption on airlines and increase profits. The clothing industry shares went up, McDonald's shares went down. These are health issues translating to everything in our society. Sure. And I argue when I talk to a politician that when you talk to you about this, this is something that is, health is a part of every conversation about wealth, productivity, and the like. These are not separable anymore. And that's, again, a very powerful incentive to do something about prevention.
Well, you said European effort should be really a global effort on the 5 continents. We need to create a network which is able to put pressure in order to reduce this massive burden of known and unknown risk factors. But coming back, John, to the primordial prevention or early prevention, do you think of lifestyle only or also of early pharmacological interventions? Now we have these fantastic new drugs, RNA-based drugs, which can give twice a year. And as Jean Browngold loves to say, we might vaccinate people against cholesterol. So what is your attitude on primordial prevention beyond lifestyle?
So it's a really, as you can imagine, a complicated question. I mean, lifestyle is important, but a lot of people can't do lifestyle. And for a lot of people, lifestyle isn't enough. So I do think we've now blessed with pharmacological opportunities that could really transform population health if done in the right way. At the moment, some of these drugs, like the weight loss drugs, long-acting siRNAs that will lower blood pressure, will lower cholesterol, are incredible opportunities. But we've got to make sure we give them in the right way and we think it through carefully. The idea that weight loss treatments are only for people who are with extreme obesity at the end stage of that process with diabetes is wrong in my view. I think we have to target weight and as part of the risk profile of future disease, intervene early, not just with lifestyle, but when necessary, use these new treatments in a much more thought through way earlier in the process of disease development. So I think we're going to see a much more radical shift of the use of drugs, which are now very conducive to compliance. As you said, you can give an injection once a year or twice a year to lower your cholesterol, also your blood pressure now. It doesn't have to be very potent if you do it early, as long as it's sustained for a long time to reduce that burden of exposure to risk factors. So I think there's a tremendous opportunity to use new pharmacology in a different way to alter the exposure of your life to risk factors. Not necessarily for everybody, but certainly it'll enhance what we can do for lifestyle management for many people.
Thank you, John. I'm reading another interesting question from Dr. Bigman. I think he's with us. You can ask your question directly.
Thank you, Professor Deanfield.
Hi.
Hi. You did a wonderful job in hypercholesterolemia, diabetes, smoking, and it helped a lot to see that this is an early detector. More and more questions are about should we already prevent children with high Lp(a) from later in life cardiovascular disease. And high Lp(a) is that frequent that has an enormous impact. Do you think that flow-mediated dilatation or other ways of finding the first clue of Lp(a) can help?
So Lp(a) is the hot new kid on the block in terms of lipids.
Absolutely.
And there's no doubt it's toxic, it's pro-inflammatory, it's an aggressive risk factor for atherosclerosis that's not addressed by the current drugs particularly well. So we've got a lot to learn about how to do that, but also when and how to do that in people with disease. But I wrote a paper in 1994. It came out in JCI, and it was for people with children with high cholesterols, looking at endothelial function in less than 10-year-olds. And it showed that 70% of those kids already had endothelial dysfunction. But what it showed was the single most important correlate with that was Lp(a). And nobody was interested at all in that. But we said that Lp(a) was a potent risk factor in FH children for early vascular damage. That's 30 years ago. So I am a believer. And I think it's really interesting to see how this is going to pan out in the trials that are ongoing now, the phase 3 trials, because we've got the ability to lower Lp(a) now in an extraordinary way. And that may transform, that be the next step forward in our management of lipid-related vascular risk. So I'm a big fan of this area. I think it's very important.
Thank you.
Thank you, John. I'm reading another question from Dr. Tabata Bey, who is with us today. Perhaps you can ask your question directly. Please.
Good afternoon. Can you hear me?
Good afternoon.
Yes.
Yeah, we can hear you.
Actually, I was wondering to know if you agree that, for example, cooks or factories should be educated to make more healthy foods. I mean, for example, very salty, very fatty, very sugary foods are very delicious, but I mean, a child or even adults want to eat food, for example, but I mean, if they make it in a way that it's more healthy, maybe it's better.
So really what you're asking,
for example,
is, should we eat healthier foods earlier? And yes, we should. I mean, the problem though is not just how you cook it, it's what the manufacturers do. All sorts of things are important. You know, this is now a massive new industry, really, about understanding the type of food that's bad, the way we eat that's bad, and the like. So food and gut health and all these things are linked together in terms of disease risk in the future. But there's no doubt that we could improve our diets and that we could actually change food composition for the better if we were minded to do that. Politicians don't like doing that because this is what they call nanny statism, you know, interfering too much with people's choices. But we've done it with smoking, and I would argue that we'll eventually have to do this now with food composition more.
John, what is in your pipeline for the future? The most exciting things you are pursuing?
Yeah, so I'm very much involved in trying to understand trajectories to disease still. Understanding intervening, when we intervene, and with what to alter evolution to disease, and trying to use intermediate phenotypes as outcomes of properly conducted clinical trials in prevention. One of the problems is that if you have to wait for strokes, heart attacks, and the like, it's very difficult to do a trial in a reasonable period of time of an early intervention. So we need to start to use intermediate markers of disease. So for example, some of the risk factors can be used as markers of disease future risk, but we want to start using imaging in a different and creative way. And I think that's going to be very exciting. Some of the work with CT scanning that is ongoing now allows you not just to look at stenosis or even flow disturbance, but actually to look at inflammatory biology of the coronary artery non-invasively. I think that's very exciting. And that work is emerging to suggest that that inflammatory biology, even in the absence of significant stenosis, has an impact on future cardiovascular risk. Again, supporting what Peter was saying earlier and what you were saying earlier, how important inflammation is in driving disease and risk. So trials in that area, I'm very excited to do that. Then I'm also interested in what you were talking about earlier on, about how we can actually change risk profiles early and see whether that can drive future benefit in a way that late intervention does not. So late intervention with new drugs is really exciting now. You know, the fact that you can take people with atherosclerosis and add to standard of care a weight reduction drug, which was developed for diabetes, and reduce cardiovascular risk significantly, to me, is incredibly exciting, because that is probably going to need to be researched. It's need to be researched in younger people without established clinical disease, because I'm sure that's going to be a new strategy for altering population health. So I'm very involved in that. And then, of course, that leads to the way in which we conduct clinical trials. These trials, as we know now, are incredibly expensive. They're hard to run, and we need new models of trial design. So I've been working with national data in the UK, something called NICOR, which is our longitudinal cardiovascular data sets, and working with UCR in Sweden on this pioneering idea that they've had that we can use routinely collected data to simplify and make more accessible clinical trials. So doing registry-based randomized clinical trials to deliver outcomes more cheaply, more quickly, and in a more effective way for patients is something I'm very interested in. We just did our first one. We published our first one together with the Swedes just recently on dapagliflozin, early after myocardial infarction, just to make the point that you can recruit randomize and see outcomes based on routinely collected data in a structured way and do clinical trials more effectively. I'm interested in pursuing that going forward.
John, coming back to the dialogue, this is a question I ask all our guests. How can we improve our dialogues? Suggestions?
Well, I think these dialogues are fantastic. You started off by taking real experts and looking at their personalities and what they've done. In a sense, you're still doing that. But actually what it's morphing into, I think now, is a discussion between people, and having the audience more involved around a topic is actually very interesting as well. So putting 2 or 3 people in the room who've worked on a topic in a different way, in a sense what we're doing today, with some personal reminiscence and the like, is a really exciting way to, if you like, take the scientific interest to an even greater level. You can not only hear someone's opinion, but hear the way in which they interact with others working in the field. I think that would be a very nice way to build on what we've been doing in the dialogue series, which are largely about individuals' contributions. So I think the fact that you and I are talking, Peter Libby's on the call, and we're talking about inflammation together, and we have approached it from a different or completely different angle on the same question is very interesting.
Thank you, John, for your suggestions. Peter, any final comment, question, or remark?
Well, I think maybe another distilled message for the younger people who will be tuned in or who will look at this in the social media is that medicine and science is actually a social enterprise. And I think one of the things you witnessed here is how personal relationships can not only push the science forward, but also we can have a lot of fun. And so I think that you've seen the collegiality here. We're delighted to have an international presence here on the Zoom. And so bottom line, we work hard, we establish friendships, and we have fun.
Thank you, Peter. It's been another fantastic hour with our dialogue, a lot of interaction, and really also I find interesting to expose also the human side of our top scientists, what is behind the scene, which is, I think can be inspiring, in particular for our younger colleagues. So thank you very much for this fantastic dialogue. Thank you, John. Thank you, Peter. Let me announce that the next dialogue will be, as usual, on the last Thursday of the month, will be on March 28th, and will be hosted by Carlo Patrono. Carlo, perhaps you can announce briefly what will be the next dialogue.
Well, it's right on the topic that we were just discussing, GLP-1 receptor agonists and cardiovascular disease prevention. So I hope many of those attending today's dialogue will also attend the dialogue on this challenging topic that John today has brought to the attention of potentially earlier utilization or testing with different kinds of primary endpoints than required when these trials were done in the adult population.
And this will be in March. And in April, well, today a lot of discussion on endothelium. Well, our guest in April will be the Nobel laureate, Lou Ignarro. He was awarded the Nobel Prize for the discovery of nitric oxide. So I'm sure it will be another fascinating discussion. Thank you very much for your time. And again, it's been a wonderful hour. Stay tuned, stay with us. We'll come back next month. Bye-bye.